John, thank you very much. To answer your question, whether or not you played a role in mentoring me as a junior faculty, not a resident, the answer was yes. In fact, John sent me, as he usually does, sends me usually a Thanksgiving, Happy Thanksgiving or a Merry Christmas each year. And I told him that this year I was very thankful for John's influence on me as a junior faculty member and he was very instrumental in that. Put up with a lot of my ways, and I'm sure I challenged him as well. But again, I think a lot of my success I owe to John and my time at UT Houston. I'm forever grateful for being there, John, and thank you. And it really is a pleasure to be here today to talk about something that is not controversial. And so when he asked me to talk about something educational, I chose this topic to do because we've done a lot of work with this with the board. And I also thought it was germane given John's role with the ACGME. I don't have any disclosures. I am employed by the University of Nebraska Medical Center as well as Nebraska Medicine. As John mentioned, I am a director for the American Board of Surgery and the American Board of Family Medicine, although I don't represent them here today. Although one of the benefits of being with the American Board of Surgery is you have access to a lot of material, slides, and I did ask Dr. Malangoni and Dr. Lewis for permission to use some of their slides for this talk, as well as Eric Holmbo from the ACGME regarding competency medical education, and I'll use some of those today. Again, as a disclaimer, just to point this out, the opinions expressed are my own, are not reflective of any actions, positions, or decisions of the American Board of Surgery or the ACGME or the American Board of Family Medicine for that matter. I think the objectives of this talk today are first to review the history of residency redesign, how did we get to where we are, examine the current state of general surgery residency training all the way up to the first trial, and then start to discuss competency-based medical education and how that might play a role in the future, and then introduce the concept of EPAs, otherwise known as entrustable professional activities. I think you'll probably also note that I've already used more slides in Dr. Potts' presidential address, and I'll probably use a few more, John. So as this slide says, well, yes, it's a routine procedure if you routinely have someone slice open your body with sharp instruments and then fiddle with your insides. The question is well, how do we get this to be routine for all of us? I mean, it's something now we probably just take for granted, but how do we get there? And that brings us to the history of residency redesign. And I think it's important to remember that those who can't remember the past are condemned to repeat it, and fanaticism consists in redoubling your efforts when you've forgotten your aim. And I think one thing you'll also notice here too is that every time we think we have something new and novel of how we're going to approach education, the fact is somebody's already thought about these things a long time ago. So the surgical training back in the 1800s was really in the form of trade schools. We really didn't have medical schools at that time. Surgical training was poorly organized. There was no standardized curriculum. In fact, there are a few teaching hospitals. Anesthesia and asepsis at that time were only slowly gaining acceptance, and there was limited operative experience. Of note, the American Medical Association was founded in 1847. Now, the effect of the Civil War led to the realization of the need for surgeons. There was only a few trained surgeons at that time. And as a result, in the major battles, there were over 1,000 deaths and over 10,000 casualties. However, much practical experience was gained, and as a result, the concept of experiential learning became accepted. The German School of Surgery had a prerequisite medical education that they also integrated with experimental medicine along with clinical teaching. It required a hospital experience, and it was a progressive responsibility with a demonstrator, as shown here, as well as an assistant, a first assistant, and they were called faculty, and they were full-time teachers. Again, they attracted the best and the brightest, something we try to achieve today as well. The Halstead School of Surgery was established in 1890 at Johns Hopkins Hospital. The goal was to train professors of surgery, and there was a very, very defined structure with an emphasis on clinical practice and independent practice prior to completion. However, it was an autocratic, pyramidal system that took on monastic characteristics. Now, the Flexner Report in 1910 really established the lay of the land and called out the critical lack of hands-on clinical experience in medical education. And of note, most physicians were general practitioners. In fact, when I was a child growing up in northern Wisconsin, The general surgeon there was a general practitioner, taking out gallbladders, doing mastectomies. That's just the way it was back then. Of note also, there was only one residency position for every 3 medical graduates. And it's also important to realize that this critical assessment of medical education was not initially carried over to residency training. It's also important to point out that Flexner described the role of time in training and quoted, "The endeavor to improve medical education through ironclad prescription of curriculum or hours is a wholly mistaken effort. Yet today we still do things on a time-based fashion." Now, the American College of Surgeons efforts were noted in 1919. You had to be a graduate of an approved medical school, internship at a, quote, creditable hospital, not sure what that is, 2 years as a surgical assistant under a preceptor or an equivalent experience. You had to have visits to surgical clinics. You had to submit a case list, although there were only 50 cases had to be given. 5 to 8 years of practice experience, and over 50% of your practice had to be in surgery. The American Board of Surgery requirements were introduced in 1937. You had to be a graduate of an approved medical school, internship at an approved hospital, 3 years of intermediate training with integration of basic sciences and clinical care, 2 years of surgical hands-on experience, a case list was required, and most importantly, you had to pass the certification exam. The Churchill model was introduced in 1939, and it called out to avoid repetitious performance of routine procedures. So you're starting to see the education versus service stuff already being called out. Provide earlier exposure to the OR. Again, something the board just introduced most recently with the 250 case requirement by PGY2. Basic science should be integrated into clinical training, and training should be flexible and tailored to the individual. Again, not a novel concept for where we're trying to head now. We have progressive responsibility was a necessity, and an advisory board for GME was needed, even back then. What are some of the seminal events that we've seen that have impacted residency? And I'll spend a little bit of time on this later on as well. The RRC for surgery was formed in 1950, and the chief resident year became mandatory at that time as well. While 5 years of training was preferred, 4 years was okay, but 8 years later, 5 years of training was required. In the late 80s were known for a reduction in the number of residency programs. And I don't think we have to note anybody here that the duty hours were brought in 2003 and then revised in 2011. Some of the megatrends in surgical training. In 1966, Medicare and Medicaid were introduced, which influenced how we hired faculty and led to the development of practice plans. The 80s were known for a shift to outpatient surgery with a reduction in open abdominal operations, as well as non-operative management of blunt abdominal trauma, peptic ulcer disease, and common bile duct lithiasis. The 1990s were known for an expansion of minimally invasive surgery with a reduction in open abdominal operations. And laws were introduced in 1996 that for Medicare and Medicaid patients, you had to be in the operating room for the key portion of the case in order to bill for it, again, requiring increased faculty supervision. And it goes back to Dr. Poth's presidential addresses, what is appropriate supervision? I thought that was just a great question. Again, 2003, the ACGME duty hours reduced time for education and experience, and then when they revised the hours, it delayed exposure to call, prompting some people to say the 4th year of medical school has now become a 5th year of medical school in the internship. So what's the current status of general surgery residency training now? Whoop. Does it go back? Can you go back one? Next one. So we have a history of producing some of the finest surgeons in the world, although many factors or changes have impacted the resident experience. Again, as it's been pointed out here already, the general surgery certifying exam fail rate increased from 14.6% in 2003 to 28.4% in 2012, although it's since declined to about 20 to 22%. Over the same period of time, the QE failure rate has remained unchanged. So their ability to apply the knowledge appears to be influenced here. We also have several studies out there that suggest recent resident graduates are less prepared for independent practice. From Matar, the fellowship study, Dr. Lewis in 2012, and Dr. Sandhu in 2015. Other issues with general surgery training, again, these have been brought out too. Inadequate surgical exposure and experience in medical school. This has led to the development of boot camps and preparatory classes during the fourth year of medical school, which have been, I think, very successful. We have highly variable training amongst the institutions that's influenced significantly by program size. Reduced breadth, complexity, and techniques in operative experience, even though volumes have increased. We also have increased specialization in general surgery, with over 80% of our graduates now going on to do a fellowship with differing needs and objectives in training broad general surgeons versus specialists. There's also variable accreditation in the post-residency fellowships, which I believe at last was 23 fellowships that are out there right now. This slide depicts the variable training we see for passing the QE and the CE. Most of them are in the upper right-hand corner, although you can see it is quite variable where programs land out. Now, if we look at this by program size, you can see that the smaller programs are at a disadvantage. They just don't have as much wiggle room as the larger programs. So the more residents you have in your program, the more likely you are to have a better pass rate on the QE and the CE first-time pass rate. Other factors impacting general surgery training have been the technology explosions that have advanced upon the scene that require us to be more and more familiar with what that is. Changes in disease management. Peptic ulcer disease is now treated with antibiotics. That was the focus of my research when I first arrived in Houston and kind of went away. I had to figure something else out, and I ended up joining hands with Fred Moore and starting to study the role of the gut in multiple organ failure, which took on a life of its own at that time. We've also had the introduction of the electronic medical record and IT onto the scene, which has made life so much easier for students and residents and faculty as we move forward. There's been a greater focus on quality and safety than ever before, and that's not going to change. That's going to get worse with reimbursement being tied to quality and safety. That's here to stay. We've also had changes in social values, public expectations, and politics have been introduced into the scene. This is a slide, again, borrowed from Dr. Lewis and was presented at the American Surgical back in 2012, and it demonstrates what the impact of the 80-hour work week is. Some of you may have seen this, but if you haven't, it's worth taking a look at. If you assume that we did a 100-hour work week before the duty hour requirements came in, that meant we worked 24,000 hours a year, or 24,000 hours in a 5-year period. It was 90 hours, it was 21,600, and if you reduce that to 80 hours, it's 19,200 hours over a 5-year period. What that meant is you had a 4,800 hour reduction, or 4,800 hour work weeks, which meant a year was taken out, or if it was 90 hours per week, you took 6 months out of the residency program. If one assumed that Monday through Friday daytime activity was 12 hours a day for 5 days, that's 60 hours a week. With a 100-hour work week, you had 40 hours of work left to cover nights and weekends. With an 80-hour work week, you only have 20. It's pretty simple math. As a result, the 80-hour work week has taken approximately 6 to 12 months of in-hospital training out of residency, most of it at night and weekends. It's also brought about something else. This slide demonstrates the false reporting and non-compliant rates for all residency programs. And as you can see, for all respondents, it's about 43% false reporting. And for the non-compliant programs, it's about 53%. And look at surgery. We have a 62% rate for false reporting and a non-compliance rate of about 68%. If I didn't know better, it would appear we've taught our residents how to lie. Duty hour results. Resident work hours have definitely decreased. We have an improvement in resident mood and burnout, reduced R1 operative volumes, problems with continuity of care, decrease in continuity of education, no improvement in patient care, really. There's been negative effects on professionalism and decreased experience with emergent conditions. Now we have the first trial. This is the New England Journal of Medicine trial that just came out, presented at the Academic Surgical Congress here in February, and appeared in the New England Journal of Medicine. This was flexibility in duty hour requirements for surgical training trial, funded by the American Board of Surgery, the American College of Surgeons, and the Accreditation Council for Graduate Medical Education. Again, it was a pragmatic cluster randomized trial that looked at surgical residency programs in hospitals and randomized one arm to the intervention arm where they allowed flexibility in the duty hours versus the usual care hospitals where you did the current duty hour requirements. There were 154 hospitals and 118 programs. And the major results of that study, no difference in primary outcome, which was death, no difference in secondary outcomes except failure to rescue during adverse events and renal failure, although the differences were too small. There was no difference in resident satisfaction. There did appear to be improvements in resident perception of patient care with fewer handoffs and less leaving during OR cases. However, there was a negative perception of personal time, but that was not deemed significant. Overall, residents thought that there was no difference with benefit towards better patient outcomes with statistically insignificant effects on personal time. And if you've been checking your emails, the American College of Surgeons just put out a recent survey that surveyed all the program directors in this, and they thought that patient safety and outcomes were actually improved. They certainly weren't worse with the flexibility in duty hours. And as Dr. Lewis pointed out, we've put the primary focus back on the patient as opposed to watching the clock. So what do we have now? We have a heterogeneous end product with segmented care delivery, a reduced continuum of care experience. We do have more cases, but there's less breadth and complexity of cases. There appears to be less autonomy, which I think Walt Biffle is going to address later on this afternoon. And confidence, independence, and patient ownership appear to be decreasing in our residents. What are the causes of this? Again, I'll point out the increasing legal constraints that have changed the ethical environment that requires supervision of residents, so we don't really have chief resident cases anymore or services. There's also a greater and greater financial pressure to produce RVUs by our faculty in order to get paid. And while the residents during their time as a resident aren't considered board eligible, one day after residency, surgeon is board eligible and legally autonomous. Thus, autonomy and independence for residents is limited and generally occurs in post-residency fellowships today unless we do something different. Are residents prepared for fellowship? This is the fellowship study that was brought out by Matar in 2013. They surveyed the Fellowship Council directors. They had a 63% response rate, 156 programs, 210 fellows a year. Conclusions. Some of this has already been said as well at this meeting. 21% of the PDs thought that new fellows arrived unprepared for the operating room. 30% could not independently perform a lap chole. 2/3 were unable to operate unsupervised for 30 minutes of a major procedure. Laparoscopic skills, 30% couldn't atraumatically manipulate tissue, 26% couldn't recognize anatomic planes, 56% could not suture laparoscopically. 24% were unable to recognize early signs or complications, 38% demonstrated lack of patient ownership, and over 50% were unable to conceive, design, conduct research studies. Again, this was a survey of the fellowship directors. What do the residents think? American Board of Surgery surveyed the residents, I think back in 2013. I'm not positive about the date, but this is the result of the study. And these are the ones who were taking the exam. And when asked, they answered that more than 9 in 10 general surgeons, or over 90%, were very confident in their ability to independently perform a laparoscopic appendectomy, laparoscopic cholecystectomy, exploratory laparotomy for small bowel obstruction, inguinal herniorrhaphy, ventral herniorrhaphy, and 87% were confident with the right hemicolectomy as well. So what weren't they comfortable with? They weren't comfortable with an AV fistula for dialysis. They weren't comfortable with a colonoscopy with polypectomy, and they weren't comfortable with laparoscopic Nissen fundoplications. What are the operative stats? These are from 2014. Laparoscopic cholecystectomy. The median is 118. That's an awful lot of lap choles to not be comfortable doing a laparoscopic cholecystectomy. I would submit that if they're doing 118 choles, either the reporting's inaccurate or there's something wrong with the way we're teaching our residents how to do a case. Again, these data conflict with Matar. Case numbers for common operations appear to be adequate. There's more than 150 laparoscopic procedures being done. and the residents report confidence in performing these common operations. Thus, the data regarding preparedness for fellowship are inconsistent, which makes clearly defining the problem difficult, to say the least. There's also two different objectives with a general surgery residency. It's designed to provide core general surgery training prior to specialty training in multiple disciplines, and provide full training to create a general surgeon who is able to treat a wide range of procedures in all environments, including emergencies. Thus, the current 5-year training program is one size fits all for both. I would submit that there are a number of evolutionary influences at play here. We have changes in disease prevalence, intensity, and management. We have changes in knowledge acquisition by our residents and our students now. They Google everything. They don't have to have it right at their fingertips. They know it. Changes in career paths, changes in duty hours, changes in expectations with teachers, learners, and patients. I think we know the answer to the question with what happens if we fail to adapt to change. Sometimes it appears as though we're just running in place. As was quoted by Lewis Carroll here, you see, it takes all the running you can do to keep in the same place. And sometimes it appears that's exactly what we're doing. And if you go back to Einstein, he quotes insanity as doing the same thing over and over again and expecting different results. Is it time to consider redesigning our general surgery residency programs? You can imagine my answer to this is probably yes. It's not a new concept either. 2004, the American Surgical Association Blue Ribbon Panel called for such changes. They called for a period of basic training with clear objectives defined in a curriculum. They called to improve the use of training resources by advancement into a specific field of interest earlier in training. They also called to enhance the general surgery experience and then to fulfill our country's needs both in rural and urban areas and equip our trainees with the skills necessary to work in these different scenarios. Demonstration of competency needed to occur at 2 levels. First, at the completion of basic training, which I would call core training, and then at the completion of a specialty module. And that brings us to the next topic. What about competency-based medical education? We've already moved that into our endoscopic requirements. What about it for overall training? What is a competency anyway? A competency is an observable ability of a health professional integrating multiple components such as knowledge, skills, values, and attitudes, and they serve as the framework for educational outcomes of the individual. By definition, competency-based medical education is an approach to preparing physicians for practice that is fundamentally oriented to graduate outcome abilities and organized around competencies derived from an analysis of societal and patient needs. It de-emphasizes time-based training and promises a greater accountability, flexibility, and learner-centeredness as opposed to educator-centeredness. Some of the drivers of early competency-based medical education, again, we're growing evidence and concern around quality and safety problems. I think everybody's seen the book, To Err is Human. Costs of training, including depth, have gone up. We have the uneven or heterogeneous end product with too many trainees graduating with deficiencies. And again, as Dr. Potts pointed out, these have to be reported and you have to attempt to correct them. The desire to improve educational and clinical outcomes. And I will also add, most importantly, is linking our educational and clinical outcomes together. I've already pointed out inflexible training models, one size fits all. It's a pluripotential stem cell philosophy. And we have several gaps in our training. These are some of the gaps going into unsupervised practice. Office-based practice competencies with interprofessional team skills, clinical IT meaningful use skills, population management skills, reflective practice, and continuous quality improvement skills. We also have gaps in our care coordination, continuity of care, leadership and management skills, systems thinking, and procedural skills. So what are the fundamental characteristics of competency-based medical education? Graduate outcomes in the form of achievement of predefined desired competencies are the goal in this model. Competencies are derived from the needs of patients and then organized into coherent guiding framework. Time is a resource for learning in this model, not the basis for progression of competence. Teaching and learning experiences are sequenced to facilitate an explicitly defined progression of ability in stages. In this model, learning is tailored to the learner's individual progression in some manner, and it consists of numerous direct observations and focused feedback that contribute to effective learner development of expertise. Assessment in this model is planned, systematic, systemic, and integrative. Now, in the traditional model, the curriculum was created with educational objectives that were assessed. In our competency-based model, we first look at the health needs and our health systems and society, and this drives what we want for our competencies and our outcomes, which then link assessment and curriculum, which must be integrated with assessment driving learning and learning driving assessment. What are the outcomes? The Institute of Healthcare Improvement defines the triple aim as patient experience that is safe, effective, patient-centered, efficient, timely, and equitable, that leads to a healthier population at a lower per capita cost. How do we link the clinical and educational outcomes? Well, first we need to look at how did the learners react to the work-based learning experiences. Was it enjoyable for them? What knowledge, skills, and attitudes have they acquired as a result of doing this? And how has that changed in their professional practices? And that, in fact, is what the competencies are, which then drive the patient outcomes that we want to achieve in the triple aim: patient experience, healthier population, and a lower per capita cost. How do the two compare? This is process versus the outcome approach. So in the competency-based approach, it's learner-centered versus educator-centered. It's non-hierarchical versus hierarchical, and the responsibility is for both the student and the teacher, not just the teacher. In our current way of teaching, it's knowledge acquisition appears to be the goal, whereas in competency-based medical education, it's knowledge application and critical thinking. The typical assessment tools are multiple objective measures, which are authentic and mimic real-time tasks of the profession under direct observations that aren't gestalt. They tend to be criterion reference, and they also have an emphasis on formative as opposed to summative. And with program completion, it's usually a variable time as opposed to a fixed time in the structured process. Again, how do you assess for the desired outcome? We want to make sure they know they have the knowledge, and we can do this through multiple choice questions. They want to know how. This is the competence, the diagnostic reasoning. Then they have to be able to show how with standardized patient simulation, and then does. They actually do it in the performance and practice with multiple source feedback with numerous direct observations. And these are work-based assessments, mostly accomplished through observations and questions by the faculty, team members, fellow residents, peers, and other coworkers, sometimes known as a 360. Now, milestones, by definition, is a significant point in development. They should enable the learner and the program to know an individual's trajectory of competency acquisition. We know where they are, we know where they've come from, and we know where they're going. However, the journey is not a straight line. There's more than one path, but you can't have an infinite number of paths to get there. As the old saying goes, if you don't know where you're going, any road will get you there. What about entrustable professional activities? EPAs represent the routine professional life activities of physicians based on their specialty and their subspecialty. What does the concept of entrustable mean? It's a quote, a practitioner has demonstrated the necessary knowledge, skills, and attitudes to be, quote, trusted to perform this activity, and here's the key word, unsupervised. In 2015, and I guess I should update to 2016, a unit of professional practice that can be fully entrusted to a trainee as soon as he or she has demonstrated the necessary competence to execute this activity unsupervised. They're part of essential work for a qualified professional. It requires specific knowledge, requires skills, and it requires the correct attitude. It's acquired through training, and it leads to a recognized output. It's observable and measurable, leading to a conclusion. and it reflects the competencies that we expect for our profession. EPAs together constitute the core of our profession. Now, if we look at EPA development by specialty, you'll notice at the bottom that we don't have any yet. And that's something that the current American Board of Surgery is actively looking at, and we hope to have some input into that at the June retreat. But you'll notice that all the others have quite a few here that are already underway. Family medicine has 76. That seems to be a bit much, but again, they're working on it. Now, if we put this together and we look at milestones and EPAs together, the important thing to realize here is that the development is a nonlinear phenomenon. They're going to go up and down this little thing as they make the progression from novice to proficient to expert and master. And you're going to have some that go above that line and finish quicker. And you're going to have some probably that fizzle out and just really don't ever get there. And as a result, they kind of fade out and they go into some other profession. How do you put all these together? And again, as I mentioned earlier, we have to look at a society and our patients and what their needs are. And we have to analyze that to understand it. Then we have to synthesize, educate, and evaluate what those competencies are to get there, to create the milestones, and then put the EPAs into training that become EPAs in practice. The bottom line, competencies, milestones, and EPAs make what has been implicit in graduate medical education explicit. Competencies, milestones, and EPAs enable a healthy examination of what it takes and means to be a proficient and expert physician. Milestones and EPAs are designed to help operationalize the more conceptual competencies in more practical terms and language, and enable more effective implementation of competency-based medical education. We're now moving from a what stage with the competencies to a how implementation stage, using milestones and EPAs as enablers. The implementation is always difficult and a messy task. It's the old bench to bedside challenge. So residency redesign, is it time? That was my question I asked. I think the answer is yes. I think the next steps are for us as an organization and a society is to analyze health needs of our health systems, to implement learner-dependent education, improve our competency assessment tools, enhance surgical experiences with earlier exposure, both in numbers and complexity. We also need to improve our faculty development to augment their teaching and assessment skills. And I would also concur with what Dr. Poth said. We have to figure out a way to work in appropriate supervision into our curriculum. It's going to require commitment, resilience, ownership, and continuous learning from our residents and our faculty. However, residency redesign should only be implemented after careful deliberation and vetting with stakeholders, as getting it wrong would be devastating. However, the American public deserves the finest surgeons and the highest level of care in the world. And I also would point out it's our obligation to commit to providing the best education for our trainees to meet both the public and our expectations of them. Again, I'd like to acknowledge Dr. Lewis and Dr. Malangoni of the board, Dr. Evans, who's chair of the American Board of Surgery, and Eric Holmbo from the ACGME offices. Also like to acknowledge the General Surgery Residency Committee that I've had the privilege to lead the past 2 years, a committee that Dr. Potts actually led when I first took on into the American Board of Surgery. I'd like to close with this slide. Education is not the filling of a pail, but the lighting of a fire. Thank you very much. It's been an honor to be here today. John, really a privilege to do this for you, and I appreciate the opportunity very much. Thank you.